Chapter 38, Heart Failure. Heart failure is a complex clinical syndrome, resulting in insufficient blood supply and oxygen to tissues and organs. This decreased cardiac output leads to decreased tissue perfusion. The ejection fraction, which is the amount of blood pumped out of the left ventricle with next systole, is also impacted. It could be classified as either heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. Often associated with cardiovascular diseases, it is increasing in incidence and prevalence. And it is also one of the most common causes for hospitalization in the elderly. For our first case study, MW is a 78-year-old woman admitted to the hospital with shortness of breath. She has a history of hypertension and coronary artery disease. Her third MI was 8 months ago. She states she just ran out of her drugs a week ago and has just not gotten around to getting them refilled. What factors in MW's history increase her risk for heart failure? And what other factors might you question her about? Everything from advanced age, hypertension, MIs, and not taking her cardiac drugs. You could also ask her about risks related to diabetes, high cholesterol, obesity, smoking, thyroid disorders, history of rheumatic heart disease, infections, or other valvular disorders. One of the primary risk factors is hypertension. While a modifiable risk factor, if aggressively treated and managed, incidence of heart failure can be reduced by 50%. The etiology of heart failure, it is any interference with mechanisms regulating cardiac output, from the primary causes being conditions that directly damage the heart, or precipitating causes, such as conditions that would increase the workload on the heart. Before caring for RW, you quickly review the pathophysiology of heart failure. How is her heart failure classified, and how does the body try to compensate for that heart failure? In left-sided heart failure, being the most common, this results from the inability of the left ventricle to empty adequately during systole or fill adequately during diastole, further classified as systolic heart failure or diastolic heart failure. In the case of left-sided heart failure, as blood backs up into the left atrium, that increased pulmonary hydrostatic pressure causes fluid leakage from the pulmonary capillary bed into the interstitium and then the alveoli. Heart failure with reduced ejection fraction is an inability to pump blood effectively and caused by impaired contractile function, increased afterload, or mechanical abnormalities. On the other side, heart failure with preserved ejection fraction is an inability of the ventricles to relax and fill during diastole, resulting in decreased stroke volume and cardiac output, and this is primarily caused by hypertension. Heart failure with preserved ejection fraction results from that left ventricular hypertrophy. Again, from hypertension, as it puts greater strain on the heart, it causes that heart muscle to grow to compensate. Though with that increased size means a decreased ability for it to pump effectively. It could also be secondary to older age, female, diabetes, and obesity. Not to be confused with right-sided heart failure, where the right ventricle does not pump effectively. In this case, fluid backs up into the venous system, and as the fluid moves into tissues and organs. Left-sided heart failure is the most common. And finally, biventricular heart failure. And this would be dysfunction of both the right and left ventricle, and involves an inability of both ventricles to pump effectively. Fluid builds up and venous engorgement results, along with that decreased perfusion secondary to left failure. Some of these second compensatory mechanisms within heart failure, one would be the renin-angiotensin-aldosterone system that works to provide homeostasis. The goal is augmentation of preload in the contractility to maintain cardiac output. This neurohormonal response, as cardiac output falls, renal perfusion decreases and renin is released. This works to release aldosterone from the adrenal cortex and results in sodium and water retention. It also is compensated with peripheral vasoconstriction, as well as the pituitary gland releasing antidiuretic hormone to encourage reabsorption. Another compensatory mechanism is the sympathetic nervous system. The baroreceptors sense low arterial pressure. In this case, they stimulate B adrenergic receptors to increase the heart rate, as well as the ventricular contractility. Other compensatory mechanisms contributing to the development of heart failure. One would be ET, which is a vasoconstrictor peptide. Another would be pro-inflammatory cytokines that are released to further depress heart functioning, causing hypertrophy. Here in figure 34-3, we have the dilated heart chambers from the textbook. Dilation, or the enlargement of the heart chambers. This occurs when pressure in the left ventricle is elevated over time. Initially effective, eventually this mechanism becomes inadequate and cardiac output decreases. Hypertrophy may also occur. This is an adaptive increase in muscle mass and heart wall thickness. Just like working out any other muscle. If you went home and lifted weights every day, your muscles get bigger. As your heart works harder, the muscles within the heart get bigger. And here in figure 34-3, we also have a diagram of those thickening, overworked heart muscles and the space that takes that results in the heart being unable to pump blood adequately. Here we just have both figures side by side as a comparison to show the effect that enlarged heart muscle has on the structure of the heart. And finally, remodeling. This is a result of continuous activation of the neurohormonal responses. Combined with hypertrophy of the ventricular myocytes, the ventricles become larger but less effective in pumping. This can cause life-threatening dysrhythmias and even sudden cardiac death. In case of beneficial counter-regulatory mechanisms, the first would be natriuretic peptides. These are released in response to increased blood volume and ventricular wall stretching. They help to cause diuresis, vasodilation, and lowering the blood pressure. Other counter-regulatory mechanisms would be nitric oxide and prostaglandin. They're released from vascular endothelium in response to compensatory mechanisms. These work to relax the arterial smooth muscle, resulting in vasodilation and decreased afterload. MW's emission assessment reveals alert and oriented to person, place, and time, fine crackles bilaterally within the lower lobes, shortness of breath on minimal exertion, and an O2 saturation of 89% on room air. MW's admission assessment reveals S1 and S2 sounds without murmur or extra heart sounds, a blood pressure of 100/60, heart rate 84, a respiratory rate of 28, and a temperature of 36.1 degrees Celsius. Her capillary refill is sluggish in lower extremities, though normal in the upper extremities. She also has +2 edema bilaterally in her lower extremities. Based on these assessment findings, what type of heart failure is MW displaying? Looking at these symptoms, she has mixed systolic and diastolic failure symptoms, so it would most likely be biventricular failure. Let's look further at the classifications. In your textbook, Table 34-3 shows a comparison of the stages of heart failure, as well as their functional classifications. Or what other clinical manifestations of heart failure would you assess MW? Do you think her heart failure is acute or chronic? Our first classification would be acute decompensated heart failure. In this case, there is an increase, usually sudden, in the symptoms of heart failure with a decrease in functional status. This requires rapid escalation of therapy and hospitalization, as pulmonary congestion and volume overload due to sodium and fluid accumulation can occur. In the early manifestations, that increased pulmonary venous pressure can result in mild increase in the respiratory rate and a decrease in the PaO2. Later, the interstitial edema can result in tachypnea, shortness of breath, with further progression resulting in alveolar edema. Can also manifest as pulmonary edema. This is a life-threatening situation as the alveoli fill with fluid. It's most commonly associated with left-sided heart failure. Because you got to remember, the right side of the heart is pumping blood fine. It's pumping it to the lungs, and as it comes back to that dead pump on the left side in left-sided heart failure, it has nowhere to go, so it backs up to the lungs. Remember the acronym, left to the lungs, right to the rest. When it comes to remembering where fluid backs up, left-sided heart failure goes to the lungs. Right-sided heart failure goes for the rest of the body in the form of edema and jugular venous distension. Here on figure 34-2D from the textbook, we show a failure of the lymphatic flow and worsening of left-sided heart failure, resulting in further movement of fluid into the interstitial spaces and into the alveoli. Our clinical manifestations of pulmonary edema include anxious, pale, and cyanotic, dyspnea, orthopnea, tachypnea, paroxysmal nocturnal dyspnea, and use of accessory muscles. They can also have cough with frothy blood-tinged sputum, crackles and wheezes, tachycardia, hypotension, and abnormal S3 sounds. Based on hemodynamic and clinical status, patients can be categorized into one of four groups: dry warm, dry cold, wet warm, which is the most common, and wet cold. In the case of chronic heart failure, it could clinically manifest as fatigue, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, cough, tachycardia, and palpitations. Edema, which could be liver, abdominal cavity, lungs, or the edema may be pitting in nature and extreme fluid buildup. The patient may also show skin changes, neurological manifestations, mental status and behavioral changes, sleep problems, chest pain, and weight changes. More to think about is what complications of heart failure will you monitor for in this patient? Some of those complications include pleural effusion, dysrhythmias, including atrial and ventricular dysrhythmias, as well as left ventricular thrombus, hepatomegaly, and even anemia. As you admit RW to your unit, what diagnostic studies would you anticipate the healthcare provider ordering? These diagnostic studies are going to determine and treat the underlying cause. First would be an echocardiogram. That provides information involving the heart valves and the presence of effusion or thrombus. An ECG may also be ordered in addition to ambulatory heart monitors, chest x-rays, a 6-minute walk test, MRIs, and also drawing of BNP levels. MW's chest x-ray demonstrates a small pleural effusion and evidence of heart failure. Her BNP levels are elevated at 828, and her ejection fraction is 25%. Goals of the therapy include symptom relief, optimizing volume status, supporting oxygenation and ventilation, identifying and addressing causes, avoiding complications, and teachings related to exacerbations. Her ABGs demonstrate mild hypoxemia, while her ECG shows evidence of an old infarction, but no new ischemic changes. What collaborative care measures would you expect her healthcare provider to order? Her care would involve continuous monitoring and assessment, along with vital signs, O2 sets, weight, mentation, ECGs, and urinary output. We're going to want to keep her in high Fowler's position to help with her breathing, as well as hemodynamic monitoring if she's unstable, in addition to supplemental oxygen and mechanical ventilation if necessary. Ultrafiltration for patients with volume overload and resistance to diuretics may be necessary as well. Also, a mechanical cardiac assist device for patients with extremely deteriorating heart failure. Here is a photo of a left ventricular assist device, or an LVADS, and this works to assist the heart with pumping blood to the rest of the body. In the case of diuretics, loop diuretics such as furosemide would be an initial go-to. We may also consider vasodilators such as nitroglycerin to reduce the circulating blood volume and improve coronary artery circulation. Other drug therapies may be morphine, which could work to reduce the preload and afterload, as well as relieve her dyspnea and anxiety. Also, positive inotropes, such as B agonists like dopamine, dobutamine, or norepinephrine. The main treatment goals would include treating the underlying cause and contributing factors, as well as maximizing her cardiac output, improving ventricular function, improving quality of life, and preserving target organ function. Other treatments would include oxygen therapy to relieve her dyspnea and fatigue, in addition to physical and emotional rest to help the patient conserve energy and decrease oxygen demand. Other drug therapies could be B-adrenergic blockers, vasodilators like nitrates, combination therapies, and those positive inotropic agents like DIG. Also, RAS inhibitors may be considered, such as ACE inhibitors, angiotensin II receptor blockers, and aldosterone antagonists. Remember to monitor potassium levels carefully in these. We could also work with inhibitors of the cardiac sinus node, such as Corlinor. This must be in a sinus rhythm with a resting heart rate of greater than 70 for this drug to be effective and considered. For our diuretics, these could work to reduce edema, pulmonary and venous pressure, as well as preload. Also promote sodium and water excretion, loop diuretics, thiazide diuretics, and monitor potassium levels. In the long-term care, they may consider implantable cardioverter defibrillators, as well as biventricular pacing and cardiac resynchronization therapies. Here from our textbook, we just have a figure showing the placement of those pacing leads within the cardiac resynchronization therapy. These patients are also going to be on a low sodium diet. The individualized recommendations and consider cultural background, though the sodium is usually restricted to 2 grams per day. These patients will also be on a fluid restriction, with daily weights being extremely important to monitor their fluid status. A weight gain of 3 pounds, 1.4 kilograms over 2 days, or 3 to 5 pounds gain over a week should be reported immediately. For further subjective data, any cardiac history of diseases that increase the risk for cardiac dysfunction. Also drugs, these are medications that are coexisting conditions. And also we need to be very aware of any over-the-counter drugs such as NSAIDs or ephedrine. Further subjective data to gain would be fatigue, depression, anxiety, their usual sodium intake, the presence of any nausea, vomiting, or anorexia, stomach bloating, weight gain, or ankle swelling and pitting edema. We also want to assess for nocturia, decreased daytime urine output, constipation, dyspnea, palpitations, dizziness, or fainting. We're also going to want to look at the number of pillows used for sleeping or orthopnea. Some patients may have 2 or 3 pillow orthopnea where they need to be sitting up much higher throughout the night to breathe effectively and sleep. Also insomnia, chest pain or heaviness, right upper quadrant pain, abdominal discomfort, behavioral changes, and visual changes. Objectively, we want to look at skin color and temperature, edema, respiratory rate and sounds, frothy blood-tinged sputum, heart rate and sounds, abdominal distension, or changes in level of consciousness. Other objective data would be serum electrolytes, their BUN and creatinine, liver function tests, chest x-ray, echocardiogram, ECG, and O2 saturation. While planning the care for MW, what nursing diagnoses would be most appropriate? Other nursing diagnoses could include impaired gas exchange, impaired cardiac output, fluid imbalance, or activity intolerance. Within our chronic heart failure planning, our overall goals are going to be to decrease symptoms, decrease the peripheral edema, increase exercise tolerance, have them adhere to their treatment plan, and avoiding any complications related to the heart failure. For health promotion, communication and joint decision making with the patient, caregiver, and the interprofessional team is key. We want to aggressively identify and treat any risk factors for heart failure to prevent or slow its progression. For the basic principles of care, heart failure is a progressive disease, with a treatment plan established with a quality of life goals. The symptom management depends on adherence to self-management protocols. Precipitating factors, etiologies, and comorbid conditions must also be addressed. What priority nursing interventions would you plan for MW? To do that, we're going to consider a lot of factors such as their respiratory status, their need for oxygen therapy. Are they always in a semi-Fowler's position to keep them up sitting high to help keep that fluid pulled down into the lungs and help them breathe? We're also going to monitor their hemodynamic status, daily weights, strict I's and O's, administer any prescribed drugs, and monitor for edema. We're also going to alternate rest with activity, provide diversionary activities, monitor response to activity, reduce their anxiety, evaluate the support system, and include patient teaching. Our transitional care programs should include comprehensive discharge planning, collaboration among providers, and planning a timely follow-up with healthcare providers. What would you include in the teaching plan for MW to prevent further recurrence of her heart failure? These signs and symptoms of worsening heart failure, telehealth and device remote monitoring could go a long way in monitoring her status. We also want to include therapeutic interventions that can be implemented to avoid rehospitalization. Here's just a picture of a guy receiving his home-based telehealth monitoring. For drug therapy, it could be basic mechanisms of action, including signs of drug toxicity, how to take a pulse for a full minute, that home blood pressure monitoring, and the signs and symptoms of hypokalemia and hyperkalemia. We could also include cardiac rehab and exercise training. This is going to be an individualized plan that focuses on the importance of rest periods in between periods of activity. We're also going to have methods for energy conservation behaviors, as well as environmental changes that may be needed. The therapeutic options for stage D include chronic inotropic therapy, palliative care and hospice, and even heart transplant. Heart failure has an estimated 5-year survival rate, with end-of-life care discussions and care emphasized, along with advanced directives, advanced heart failure therapies, and palliative care and hospice. How would you evaluate whether your nursing actions were successful for MW? First, you'd look at the oxygen saturation and assessment of their lung sounds, along with respiratory rate, capillary refill, assessment of peripheral edema, daily weights, intake and output, and did they verbalize an understanding of the teaching? Our expected outcomes would be that the patient with heart failure will maintain adequate oxygenation and CO2 exchange at the alveolar level. We also want to maintain adequate blood pumped by the heart to meet their metabolic demands. We also want to help them experience reduction or absence of edema and a stable baseline weight. Again, maintaining that adequate gas exchange to meet O2 needs, maintain adequate blood pumped by the heart to meet the demands, reduced or absence edema, maintaining a stable baseline weight, as well as a stable fluid status, helping them achieve those realistic programs of activity, and as well as conserving energy. Gold standard therapy suitable for some patients in end-stage heart failure. We want to look at a selection process that identifies patients who would most benefit from a donor heart. Also, candidates must undergo a comprehensive physical as well as diagnostic and psychological evaluation. Unfortunately, there is just never enough organs to go around, and transplant candidates are placed on a transplant list. Stable patients may wait at home and receive ongoing medical care. Unstable patients may need hospitalization for more intensive therapy. The overall waiting period for a heart is long, and many patients die while waiting. The first step in the process is heart retrieval. The second step is removal of the recipient's heart, except for a portion of the atria. These are two different approaches. And the final step is connection to the donor heart. During post-transplant monitoring, we're going to look for acute rejection, infection, a risk for cancer related to immunosuppressive therapies, as well as cardiac vascularization. Endomyocardial biopsies are done from the right ventricle weekly for the first month, and then monthly for the next 6 months, then yearly thereafter to detect rejection. Nursing care focuses on promoting patient adaptation to the transplant process, monitoring cardiac function, detecting subtle signs or symptoms of complications, managing lifestyle changes, and providing ongoing teaching. A patient with a history of chronic heart failure is hospitalized with severe dyspnea and a dry hacking cough. Assessment findings include pitting edema in both ankles, a blood pressure 170 over 100, pulse of 92 beats a minute, and respirations 28 breaths a minute. Which explanation, if made by the nurse, is most accurate? The assessment indicates that venous return to the heart is impaired, causing a decrease in cardiac output. The manifestations indicate impaired emptying of both the right and left ventricles, with decreased forward blood flow. The myocardium is not receiving enough blood supply through the coronary arteries to meet its oxygen demands, or the patient's right side of the heart is failing to fill with enough blood to the lungs to provide systemic oxygenation. And the answer here is going to be B. The manifestations indicate impaired emptying of both the right and left ventricles with decreased forward blood flow. A patient with left-sided heart failure is prescribed oxygen at 4 liters a minute per nasal cannula, furosemide, aldactylone, and enalapril. Which assessment should the nurse complete to best evaluate the patient's response to these drugs? That be A, observe skin turgor, B, auscultate lung sounds, C, measure blood pressure, or D, review intake and output. That answer is going to be B, auscultate lung sounds. Left-sided heart failure will prevent normal blood flow and will cause blood to back up into the left atrium and into the pulmonary veins. The increased pulmonary pressure causes fluid extravasation in the pulmonary capillary bed into the interstitium and in the alveoli, which manifests as pulmonary congestion and edema. The most important assessment to determine if the drugs are improving the patient's condition is to auscultate lung sounds. The other assessments are important, but the best indicator of improvement of left ventricular function is a reduction in adventitious lung sounds, or crackles. And for our last question, the home care nurse visits a patient with chronic heart failure who's taking digoxin and Lasix. The patient reports nausea and vomiting. Which action is most appropriate for the nurse to take? A, perform a dipstick urine test for protein. B, notify the healthcare provider immediately. C, have the patient eat foods high in potassium. Or D, ask the patient to record a weight in the morning. That answer is going to be B, notify the healthcare provider immediately. This patient's taking furosemide, which results in the excretion of potassium and may cause hypokalemia. The patient's also on digoxin, and the risk for digoxin toxicity increases if potassium levels are below normal and digoxin is administered. The signs and symptoms of digoxin toxicity include anorexia, nausea and vomiting, and visual disturbances, those yellow halos. Those visual disturbances are key. If you ever see sitting on ATI or NCLEX and see visual disturbances along with any anorexia, nausea, vomiting, anything, immediately hold that dose. It is a drug that is severely dangerous with toxicity. And those halos, as well as nausea, vomiting, or even light anorexia, not hungry, is all going to be signs of digoxin toxicity. But anyway, that's all we got for this chapter. I'll see you in the next slides.